Good day, and welcome to today's United States of Care NYC Playbook Briefing conference call. During the presentation, all lines will be in a listen-only mode. A question-and-answer session will follow the presentation, and instructions for asking questions will be given at that time. Thank you for your attention. I would now like to turn the conference over to Emily Barson. Ma'am, you may begin.
Great, thank you. And hello, everyone. On behalf of United States of Care, welcome to our telebriefing with the New York City COVID-19 Rapid Response Coalition, or CRRC. My name is Emily Barson, and I serve as Executive Director at United States of Care. I'm joined today by Trevor Price, U.S. of Care Entrepreneurs Council co-chair and founder and CEO of Oxyon Holdings, and Shoshana Brown, founder and CEO of AIR NYC. Thank you both for joining us. Our format on today's call will be straightforward. Trevor and Shoshana will take us through the project's impetus, structure, management, tactics, and early outcomes. It's a tall order, but we're going to do our best to keep the presentations to about 30 minutes so we can dedicate the second half of the call to Q&A. For anyone who would like to reference the playbook during this call, it can be found on the U.S. of Care COVID Resource Hub at unitedstatesofcare.org/COVID-19. Before I turn it over to our presenters, I want to take just a minute to introduce United States of Care to those new to our work. At U.S. of Care, it is our mission to ensure that every single American has access to quality, affordable health care, regardless of health status, social need, or income, a mission that has never felt more relevant and is only underscored by the acute needs during this current public health crisis. Over the past month, we have shifted to be wholly focused on providing immediate support for state and federal government and public response needs, leveraging our expertise, capacity, network, and resources to support effective responses to the COVID-19 pandemic. This briefing marks the fourth in a COVID-19 focused series. We have stood up a resource hub, which serves as a clearinghouse for materials valuable for our partners, content created by United States of Care, as well as resources and information from other entities. We have presented recommendations for federal policymakers, including an agenda released just yesterday, and we have highlighted best practices for state leaders and cataloged innovative executive orders for states to learn from one another and how to best respond to the pandemic. And we're looking beyond the state and federal lens to amplify promising locally led models from across the country, such as the topic of our call today. The New York City COVID Rapid Response Coalition, made up of cross-sector companies and organizations, formed to serve at-risk populations during the 2020 pandemic. The United States of Care partnered with leaders of the coalition to draft a playbook highlighting the replicable approach that may be valuable to other communities across the country to learn from. If you're in a city with a patchwork system of legacy healthcare and social service solutions, you're about to face hundreds of thousands of COVID-19 cases. You will need a creative, impactful way to protect and serve your most vulnerable during this pandemic. This approach requires the rapid formation of partnerships across multiple fragmented parts of the healthcare system. The playbook outlines the goals, tactics, and work streams that the CRRC is using. The goal of the playbook is to help spread this general approach across the country and encourage entrepreneurs and systems to play a role. Again, the playbook is posted at the U.S. of Care Hub, which you can find at unitedstatesofcare.org. Our goal for this briefing is to share the playbook with you all right from the source, and I'd like to say thank you and welcome to Trevor Price and Shoshana Brown. After the presentations, our moderator will provide instructions for submitting your questions. Trevor, I'll hand it over to you to kick us off.
Thank you. I just want to make sure you can hear me.
Yep, you're good.
Perfect. All right, terrific. First of all, I appreciate everyone joining the call. Shoshana and I are excited to talk about this effort that we have been undertaking for really the last month, and I say that intentionally and very purposefully to set expectations and to make sure that everyone understands that, what we have been working on and what we have been attempting to do was conceived really basically almost exactly a month ago, and we have not spent a single dollar in standing it up. And so, while myself and Shoshana and others have a tremendous source of pride for that, I think we both would say that we aren't even close to at being at the point where we have the impact that we believe something like this can have, and there's still lots of iterating and lots of testing and lots of learning and lots of improving. And so by no means are either one of us here today to present a final playbook. This is about municipalities that are trailing New York by a week or 2 weeks or a month in terms of facing some of the issues that we have faced and how we can share those resources. So I think we'll start with the impetus behind this. I think the impetus really was in looking at, and this is pre-social isolation mandates in New York City, looking at the data around the projected infection rates and then hospitalization rates and applying that to the bed capacity in New York. I think this is now a well-known and well-understood situation, but it was incredibly scary. And I think for myself and a few other people, Shoshana as well, being involved, we didn't feel like we had the tools in our toolkit to effectively flatten the curve. And so we focused much more on, could we in some form or fashion get out in front of ER and ICU utilization and find ways to try to support those who would be at higher risks of hospitalization, those vulnerable New Yorkers who would more likely than not end up in the emergency room. And we really broke that down into two different populations, and it's important to differentiate the two. The first is one that people have talked a lot about, which are the elderly or those with underlying health conditions that if they were to contract COVID-19 would be on a rapid progression to the ER or the ICU. And the second population were those who had, underlying health conditions that were supported by the kind of distributed fabric of healthcare providers in New York City that we saw as a result of, the data and what we were looking at from a COVID crisis standpoint, that healthcare system was going to become at best under a tremendous amount of pressure and at worst potentially could break down and not be there to provide services. And so those people with COPD or CHF or hypertension or end-stage renal disease, chronic kidney disease, they would see their home care workers, their transportation to dialysis, their primary care offices, their FQHCs become unavailable as a result of labor shortages or other factors. And so really out of that came a concept of, could we rapidly bring together a coalition, a group of healthcare providers and technology companies with a set of principles that included a humanitarian pro bono commitment, so everyone has to agree to put aside their competitive issues or self-interests. This wasn't about individual company growth. We committed and have held ourselves to a upfront statement of being nimble and being dynamic and making sure to focus on things that we could try to get done rapidly and quickly. And then the idea was, could we really bring together this group, coalesce it into, bring it together as an entity that felt like it was collaborating to be as one, to work together, to catalyze this effort to serve these two sets of vulnerable populations as much as we possibly could in their homes with both clinical and social services. And so with that as kind of the impetus, I will go into a description of what steps we've taken and what things we've done. Most of this, if not all of it, is covered in the playbook, but I'll walk you through it. And then I'm actually going to go in a different order than I would normally go because it provides for a much more natural segue to my friend Shoshana to jump in and explain what role and what impact her organizations and others like hers have had. So the first, if you think about the coalition, there's really three kind of distinct parts of the coalition. There is what I classify as kind of a groupthink crowdsourcing exercise amongst all of the organizations that are involved. There is a technology platform that we use to scale once we identify the vulnerable New Yorkers. We have a technology platform that scales the engagement and connections to those individuals, allows them to identify needs that they have, and then there are effectively networks of social services and clinical providers. All of that is a second component, and a third component is a governance structure, is a philanthropic fundraising effort, et cetera. I'm going to start there just because, again, as I said, it's easier to hand off to Shoshana for what we'd like her to talk about. We really did not begin with anything related to governance or fundraising or a website or anything. I will say up front, there was an immediate, at the very beginning of this, commitment to build a playbook to capture what we were doing. We created a email account that was a catch-all email for every step that occurred, for every type of person that was involved, for every meeting, for every topic. Every email that we sent was CC'd to a catch-all email address, which then we used to kind of make sure we didn't overlook aspects of it. So the playbook was actually originally part of the conception. The executive committee that we formed represents, we were fortunate enough to involve both a Democratic and Republican former head of, former CMS administrator. We have New York City public health and not-for-profit social services healthcare leaders. We have business leaders. We were very fortunate to rapidly get a group of people together. The executive committee of the group really formed close to 2 weeks into the effort, into what's now been a 4-week effort, so it feels like an eternity, but it was not done up front. It was done with an objective to be able to provide governance and structure around any philanthropic dollars we ultimately would raise and how we would distribute those to the not-for-profits and other organizations that were participating in the coalition. This same kind of what I'll call administrative function was successful in finding a very reputable, long-standing 501c3 in New York where all of our intellectual property and everything we do will be housed inside of this not-for-profit. All of the capital will be raised and held within this not-for-profit, even though our governance structure will make the decisions on where that capital is allocated. So there's an administrative governance. It makes sure we manage against conflicts of interest and all of that. I will leave it at that. It's of the three things, it's probably the least interesting to people. In my mind, the most important thing that we did that has created real momentum, a real sense of purpose, and actual very serious outcomes is this coalition stand-up call. It occurs at 7:30 in the morning. We have a Google sheet that is circulated ahead of time, and people can enter topics that they want to discuss. They can bring them up on the call as well, but generally topics are submitted ahead of time. I use the term groupthink and I use the term crowdsourcing because this forum has been an opportunity for a health system, a not-for-profit health system in the city to be able to speak to other organizations and say, we have ventilators, but we don't have respiratory therapists. Who has ideas for where we can find respiratory therapists? And within 20 to 30 minutes, that organization had 3 to 4 connections to different sources of respiratory therapists. PPE, obviously, one of the themes in these conversations, and the coalition has not only secured large pro bono donations of PPE for our community-based nonprofit organizations, but we've actually purchased PPE to be able to, we've evaluated and tested a series of supply chains, and we purchased for our organizations. This groupthink crowdsourcing effort will have topics that are discussed in a call and may or may not be updated in future calls, but ones that have a lot of energy and a lot of shared need and a lot of potential for impact are actually broken out of the 7:30 a.m. call and are put into a separate work group where the coalition has volunteer leaders and operators and project managers who are contributing, and they will lead those. So we have work groups on PPE, we have work groups on food and food delivery. I'm going to, Shoshana is going to speak more about that. This daily stand-up call for us has anywhere between 50 to over 100 participants. We try to hold pretty clear meeting hygiene, and so it ends at 30 minutes. It is not a call that we allow to go on much longer. And I think the shared sense of responsibility, the shared sense of collaboration, the shared sense of we're creating impact and we're helping each other has been invaluable. So that is the second portion of what the coalition has been doing. The third is really where we set out to try to figure out how we could actually scale the person-to-person or the scale the impact of delivering services to people representative of the two populations I outlined. This has really developed into what I will kind of describe in a marketplace metaphor, but I don't mean a marketplace because people are not buying and selling things. But on the front end, we were able to bring together the leading safety net not-for-profit health systems and the leading safety net managed Medicaid MLTC type health plans in the market. They they are obviously the ones who have close relationships with the populations we're describing, and we were able to collaborate with those organizations and get access to populations that represented the high-risk New Yorkers that we were talking about. We were able to work with, I will use the name here, it does not have to be these guys, there is a lot of chatbot technology out there, but we were able to secure a pro bono donation from Amazon Web Services to provide chatbot technology that allowed us to rapidly build and customize scripts that would be sent via SMS. We used and selected SMS initially just because the pace at which we could deploy it, we understand that a real and meaningful percentage of the people that we're trying to engage with are not likely to engage over text, but we felt like we could reach large numbers of people quickly. And so today and yesterday, this platform is texting upwards, and if not in excess of 10,000 people, and asking them a series of questions to get them to identify whether they need food, whether they need medications to be delivered, whether they need to talk to a doctor, and other series of questions. On the back end of, if that is the process of identifying the vulnerable New Yorkers and then a mechanism to engage with them, we have had to find and build what I think would be overstated by saying networks, but effectively networks of service providers to respond to and handle those inbound needs. The coalition members include organizations that deal with our food banks, our FQHCs, our in-home care delivery vehicles, our organizations that have highly trained community health workers who can have conversations with people that help understand even further what their social needs are and connect them to the resources. They include technology companies like Uber to deliver food or capsule or CVS to deliver medication. And they represent for-profit, not-for-profit, New York-based and national-based organizations that have all gotten involved to be deliverers of social and clinical needs. Before I hand it over to Shoshana, I'll say that our goal over the coming weeks and months is today the SMS platform that we're using has effectively engaged approximately 10% of the people we text. So for every 1,000 people we text, we have 100 people respond back. Some portion of them indicate they don't have any needs. Other portions of the 10% indicate that they have social services needs or clinical needs. Our goal is to both find means to increase the absolute number of text messages we've sent out. We are today reaching out to a high-risk population of 35,000 people that has been identified by a health plan in the community. And we are working all the way up to securing an entire New York State Medicaid database to be able to do high-risk segmentation on and be able to communicate with those. That is a goal. Additionally, we do have a goal that, assuming we are able to raise philanthropic funding, that this platform would be available and would be used with the uninsured. But obviously, as of today, we don't have the resources to do that. So our goal is to increase the total number of people we're reaching out to, increase the engagement rate, and be able to provide these services and cover gaps in care or gaps in reimbursement for the uninsured. So with that, Shoshana has been a partner in crime in conceiving this with me and a handful of other people, and she's also been a massively impactful and instrumental service provider and has helped us figure out what is going well and what needs to go better. And so I'll hand it over to Shoshana.
Thanks, Trevor. I appreciate it. So as Trevor said, I think what we've really been trying to do together as this coalition is to be a catalyst. It's to identify gaps, coordinate efforts, support the work of the public sector and the resources that the city agencies and officials are finding. It seems more each day, but again, stressing the nimbleness and the agility of this particular group of people to support those efforts. So whether it's supplementing the meal delivery that the city initially brought online through schools and then opened up to all New Yorkers, we still have challenges around distributing and delivering that food. Or as Trevor also mentioned, getting PPE to frontline workers such as home health aides who didn't have immediate access to PPE and desperately need it. Or frankly, reinforcing the basic public health guidance to support social distancing that wasn't getting out to everybody. So it's looking for those places and being rapid, dynamic, and having that capacity together to assess needs in real time, to do that gap analysis, and to mobilize existing resources that we can each bring. It's true that not every city in the country, every town has the resources that New York City has. And yet, even in New York City, in our resource-rich environment, this crisis has really tested us. And it's calling for everybody's best efforts to collaborate and to leave behind, whether it's, competitive practices or silos that we are all used to working in. And so what I want to share with you today is a few examples of what we've been doing here for the most vulnerable and what can be done across the country no matter where cities or towns or municipalities are in terms of their baseline. I'm going to focus on three things. The first thing is, as Trevor mentioned, the community health worker workforce. Every town, even throughout social distancing, as it kind of gets to wherever you are, has this workforce. Sometimes they're called navigators, sometimes they're called coaches, care managers, but this community health worker workforce, a non-clinical workforce, is made up of people who know the communities, where they live, they need to be leveraged right now. And when I say leveraged, I mean supported and lifted up and hired to check on neighbors, to work and think communally, to connect with seniors by phone who may not have access to SMS messaging, to help ensure that medications are available, to help connect people who would otherwise be unable to access telehealth, to get somebody on the phone with a clinician, whether it's for COVID or non-COVID health needs. You don't need sophisticated technology to do this. People don't need to have sophisticated skills and experience, really. It's about a kind of empathy and a willingness to be a part of a community. This is a playbook that is very old school. I think of it as, from the early days of small town USA and also from parts of the world where there are never enough healthcare workers, never enough PPE, never enough resources. And I mean Africa and India, Latin America. This workforce can right now help support social distancing, mitigate loneliness, check on the frail, and help people stay connected to what they need during this phase of COVID and beyond. I want to share with you two stories, specific anecdotes that community health workers from CRRC, the organization that I lead, have shared with me in this past few days. One is about an elderly man living in the Bronx who was having difficulty reading his medication label. One of my teammates, a community health worker whose family is from Somalia, connected with this elderly senior in the Bronx, asked him to get on a WhatsApp video chat, helped him read through the label, learned that the inhaler for his asthma was completely empty, which would have put him at significant risk for hospitalization if he were to have had an asthma attack. The CHW contacted a clinician and a local pharmacy to get his prescription refilled and delivered to him. The man was able to stay home and has an adequate supply of that medication. There are countless stories like this during COVID and frankly before, and I just want to make a real push around the country for people to understand that this is a very undervalued workforce and is absolutely necessary to support what we're trying to do as a country right now in this crisis and beyond. Another example was a community health worker who connected with a 60-year-old man who was having severe anxiety and didn't have enough food. This particular community health worker connected the man to both the New York City Emotional Support Hotline, which is a phone line available, a text line, and to food services in the neighborhood. Both food pantries were able to deliver food to this person. Both of these examples show that we were able to prevent visits to an emergency room during the crisis and help people stay home. I want to just be clear. We can build this workforce. We can build it in urban settings, in rural settings. We can build it in the north and the south. All we really need is a smartphone to do this right now, and it can really help people get through this. The second thing I want to talk to you about is building and forging connections within and across the social care sector. Community health workers, navigators, coaches have to have somewhere to connect people to for the services they need. Community health workers, community-based organizations, other social care providers, including those from the government and private sectors, as Trevor mentioned, who are working with us, including faith-based organizations, have to come together across the silos within the social care sector. Typically, as most of you know who work in this environment, there are serious silos and fractures between food pantries, legal aid groups, behavioral health organizations, homeless prevention groups, substance abuse and prevention organizations, and resources. We all need to come together because if this crisis has taught us one thing, none of us can do this work on our own. We have to find common languages. We have to figure out how to triage according to severity of need and prioritize. And we have to see ourselves as part of a continuum. Third, I want to make a push for the integration of social and health care. We have to fund work that addresses the social determinants of health. Prior to this crisis, there was strong momentum, and directionally, we have begun to see people around the country talking about the social determinants or drivers of health. We have to do more, and and this crisis also points out the importance of integrating social and healthcare service providers. New York State began to do this difficult work several years ago through our Medicaid redesign, and this shift was driven by all of our work to move from fee-for-service to value-based care. It wasn't an easy or perfect policy set of changes over those years, but we've made measurable progress here, breaking down barriers in terms of integration between clinical and social, and that has allowed us to reduce hospitalization in measurable ways prior to this crisis. This has to continue. We have only begun that work, but I can say that it has resulted in new relationships, new stakeholders, and lessons that we can build on as we deal with COVID right now. I want to encourage everybody on the phone that we can enact policies, and we have seen some changes and learned some important lessons within the past month that have reduced the barriers to the kind of collaboration that we absolutely need to do this work and meet the needs of vulnerable people. We need to have meaningful ways of sharing data, making it easier to refer and communicate back and forth across the systems we're talking about. Some, but not all, of this integration is about technology. Most of it is also about basic human culture, values, and behavior change. We have to value the people we're trying to serve. We have to value the workforces who are non-traditional. We have to value and enable reimbursement pathways. We have to revisit scope of practice rules, and we have to continue to create these clinical linkages. We have learned so much from the SMS chatbot exercise that Trevor just described. We have learned who we can reach with SMS technology and who we still need to reach by phone and traditional pathways. We have learned that telehealth, where it used to be accessible and available and used by more affluent cohorts of our population, is absolutely usable and valuable for everybody. We, through the help of navigators, have been able to connect people to telehealth through the phone, through the video, and through other modalities. We need to build on that. I think COVID has helped accelerate the pace with which we have all normalized to telehealth, and we would like to see, as a policy request from the U.S. of Care, this group help to further advance that. I think that in closing, I want to say that we know that the healthcare sector and the social care sector are both fragmented and difficult to navigate in this country. But it has never been more apparent that the kind of integration and collaboration that we've seen, excuse me, through COVID in New York City is where we need to go beyond COVID. Thank you. Thank you so much, Trevor and Shoshana. That was a great, both inspiring and tactical overview. So I really appreciate you walking through the details of the operation that you've stood up so incredibly quickly. Brad, if you could give folks instructions on how to ask a question for our speakers, please.
Thank you. At this time, we will begin the question and answer session. To ask a question, press the star followed by the 1 on your telephone keypad. Questions will be taken in the order in which they are received. An audible prompt on the phone line will indicate when your line is open. Please state your name and affiliation before posing your question. And again, press star 1 to ask a question. We'll pause for a moment as our system compiles your responses.
Sure, and while folks are asking their questions, I'll kick us off. I think we have a mix of government and non-governmental parties on the call, and for those who are in lawmaking, in public office or staff positions, I would love to hear your reflections on how the public part of the public-private partnership has been able to meld with external entities that are probably much more nimble and moving quickly than government traditionally does, and if you've had any lessons learned about removing barriers to facilitating that type of collaboration. I'm not sure which of you, if either of you feels moved to take on that one.
Oh, I thought you were asking. I thought you were asking the listeners. Shoshana, I don't know if you want to engage on that one. I think up front in forming what we formed, we were somewhat intentional to not get directly involved and directly under, kind of the direction of local or state or even federal government programs and officials. And what we decided to do was use the relationships that we had at all three of those levels to keep people aware and to keep people informed, but to not make it part of the kind of decision-making process. And that was intentionally architected into those founding values of being nimble and dynamic. I do think that, to Shoshana's point, that this system, or what we've done, it's the famous Winston Churchill quote of, never waste a great crisis. And I think in many ways, the collaborations and the exchanges and interactions that are happening over the last month would have been valuable before COVID. And when the COVID crisis starts to wane for the broad population, the population we're trying to serve will remain in crisis, and we continue to want to try to maximize their ability to stay well out of the emergency room. So the fundamental principles of what we're doing will absolutely remain and absolutely be central to the public health system going forward. And so I do think the government does play a role in this. I just think in standing this up in a matter of hours and days, we were intentional in trying to do that by keeping the government informed but not directly involved.
Great, thank you. Do we have any questions in the queue?
And again, ladies and gentlemen, to ask a question, please press *1. We do have our first question. Caller, your line is open. Please go ahead. Caller, if you have muted your phone, please take it off mute.
You're right. Hi, Sharon Langsher here from Abundant Venture Partners in Chicago. We are actively setting up a comparable tool based on a social service agency that already exists and has some technology underpinning it. I'd be really interested if you're willing to share some of your, governance and, the guidelines really for your executive committee. Thank you.
Yeah, Sharon, I will go ahead and send some of the material that we've produced. I think today the first and most important piece of material was conflict of interest policy. Obviously, when you get into these situations, it's a web of relationships, and everyone seems to know each other and work together, and there are not-for-profit and there are for-profit. I just think we've had to be incredibly, incredibly intentional to make sure, even before there was an executive committee, that there was never a scenario where, the coalition's efforts were benefiting a single company or a single entity, and that as the coalition has moved to the process of raising philanthropic dollars, and those philanthropic dollars will, the vast, vast majority of it will be distributed to really largely not-for-profit organizations, although there will be situations where for-profit companies are delivering either care or social services where there is no reimbursement mechanism, and so there are scenarios where some of those dollars would be allocated in that direction. We have had to be very clear and fully disclosed and transparent on any potential conflicts of interest. I think beyond that, the executive committee is meeting every other week. We've created a a steering committee for fundraising. We've committed a steering committee for grants and fund allocation. We've created there's an operating agreement with and an administrative fee to the 501c3 where we're being housed. And that's really to date what we've created, but I will share all of that with you. It's nice to hear your voice.
Thanks, Trevor. Appreciate it.
Thank you. Again, to ask a question, please signal by pressing star 1. We do have our next question. Caller, your line is open. Please go ahead.
Hi, this is Esther Dyson from Wellville. I'm curious what kind of long-term plans you might have, not necessarily you've got a 5-year budget, but what are you hoping this will have created that will last after the immediate crisis is gone?
Yeah, that is a great question, and I'll start, and I would ask Shoshana to share, because obviously she is beyond knowledgeable and incredibly passionate about this and has done more to address, the challenges faced in this particular situation. I think, Esther, we've really thought about this from 3 distinct phases. The first is this immediate crisis, which we think of as kind of the moment we kind of stood up and said, wow, we need to do something here, which let's call it mid-March, until I think we thought about it from a budgetary standpoint until the end of June, where we think hopefully this first wave in crisis will have started to be brought under control. The second phase is really what I'll call the next phase of COVID. And so, again, we really think about that, at least from a budgeting standpoint, of June of 2020 to June of 2021. And that means preparations and putting in infrastructure and improving technology and really working with the organizations that have delivered exceptional outcomes in this first phase and getting them ready to scale for a potential phase 2 situation. That also includes handling and providing funding for both social and clinical services for the uninsured. So that budget's a much larger budget, and a lot of it does come from social services payments and telemedicine clinical services payments for the uninsured. And then, I think we all, and I know Shoshana agrees with me on this, we've talked about it, I think we're all yearning for a day where we're not working 18 hours a day right now trying to figure out not only this but our day jobs. And what is the legacy of something like this in thinking about the way our public healthcare system coordinates, it aggregates needs, identifies needs, and effectively scales the coordination and matching of those needs to networks of organizations. And this coalition, and even the not-for-profit that will remain, does not intend to build social services organizations. We don't intend to be the aggregator of the network. That's not what we're setting out to do. We're not going to hire community health workers. We're not going to open, substance use clinics or food banks. But we do think there's a role for technology, and we do think there is a ability to leverage, technology on the demand side and integrate into existing networks of top networks of social services providers. And that, I think, lives beyond the COVID crisis. I just don't think we've had a ton of chance to really think about that, but I know that is something we all have very much in the back of our head. And Shoshana, I'll defer to you.
Yes. Hi, Esther. I agree with what Trevor just said. In terms of the near term, I think that very quickly we need to start figuring out testing and contact tracing in New York City as our sort of as we look to other countries. Where there are some great examples of how pods are organized and how we do this well. So I think a near-term example of what this coalition needs to quickly turn to is how can we work with the public health structure here to, again, support, catalyze, accelerate, reinforce for this next phase of COVID. 5 years does seem like a long time away at the moment, but I think we're all trying to think about all of these issues sustainably in terms of policy, advocacy, investment, technology.
Thank you.
Thank you. And again, ladies and gentlemen, to ask a question, please press star 1 at this time. And we currently have no further questions in the queue.
Great. Well, thank you again so much, Trevor and Shoshana, certainly for spending the time with us today, but, for your leadership and, just incredibly fast-acting and ability to mobilize what really is an inspiring model. I know that we got a great level of inquiries and interest from the playbook, and I think certainly just appreciate your sharing that with us to be able to let other cities who might be right behind New York start thinking about getting these structures in place, maybe in a matter of days instead of a matter of hours. So we will make sure that everyone on this call has that link and follow up. Please don't hesitate to reach out if there are any additional questions or feedback from this call. Thanks, everyone, for joining us today.
Thank you all for your attention.
Thank you.
This concludes today's conference. All participants may now disconnect.